सारी बात हो गई है।
पवन जी को हम टारगेट पे ले रहे हैं। थैंक यू।
बहुत बहुत आभार, बहुत बहुत आभार। मैं तो टारगेट पे ही हूँ।
निकोटेक्स छुड़वा दीजिए।
हम सब शिव भक्त हैं और शिव भक्त होने के नाते कुछ चीजें एक्सक्लूजन में आती है हमारे लिए।
ठीक बोले। तो मैं सभी का स्वागत
इन
करता हूँ।
के साथ में
आज अपनी वो लाइव हो चुकी है, तो मैं अब अपनी 759th वेबिनार, जो कि बड़ी एक यूनिक डिसीज पर आज है। आप मोबाइल सब बंद रखेंगे। आज एक फ्लैश ईटिंग डिसीज, और विश्वास मानिए मैं ये नए नए दिन खोजता रहता हूँ, इसलिए ये मालूम पड़ता है। अदरवाइज मुझे भी नहीं मालूम था 60 साल तक कि नेक्रोटाइजिंग फैसाइटिस कुछ होता है। ये एक फ्लैश ईटर बैक्टीरिया है, फ्लैश ईटिंग डिसीज नाम इसको दिया गया है, और बड़ी यूनिक डिसीज है। सभी विद्वान जुड़े हुए हैं। मैं आदरणीय निस्तेश्वर सर, हमसे 10 साल सीनियर है सर, वहां जामनगर यूनिवर्सिटी के गुरुवर हैं, तो मैं उनका सादर स्वागत करता हूं। और कोई विघ्न बाधा न बीच में रखते हुए आदरणीय प्रजापति जी, आदरणीय लक्ष्मीकांत द्विवेदी जी, और एक बात और मालूम पड़ी अग्निहोत्री सर से कि स्वस्थ व्रत वाले उनके परिवार के, हम क्या पड़ोस के हैं सर? हम भी आपके परिवार के।
आप संचालक है, उस परिवार के संचालक आप ही हैं।
तो सुनिए ना, तो मैं आदरणीय निस्तेश्वर सर जो द्रव्यगुण के हेड हुआ करते थे जामनगर में IPGT एंड में, उनका हार्दिक स्वागत करता हूं। और निशांत शुक्ला जी से प्रार्थना करता हूं कि निशांत शुक्ला जी कृपा करके प्रेजेंटेशन शेयर करें। निशांत जी। आदरणीय निस्तेश्वर सर। आप म्यूट हैं सर, काइंडली अनम्यूट। आप म्यूट हैं, म्यूट। आपकी आवाज नहीं आ रही है।
यस सर।
अच्छा, अभी आ रहा है ना?
हाँ,
अभी
ठीक है। स्वागत है सर।
I just welcome at the outset all the dignitaries who are participating in this webinar, and I could able to see that the second innings I am playing here, consecutive innings. Yesterday I spoke on MR, multiple sclerosis, and now NF. These all are drugs, diseases which are not described in Ayurveda. It is a challenging task given to me by Harmohan Chandolaji from Dehradun, and I accepted it. And today's topic, necrotizing fasciitis. Otherwise, it is named as bacteria, which is flesh-eating in nature. It's a life-threatening, progressive, rapidly spreading, and destroying deep fascia, and also called as flesh-eating bacteria. Other names it shares are streptococcal gangrene, Menial ulcer, and dermal gangrene, hospital gangrene, necrotizing cellulitis. Definitely, you have to make a differential diagnosis between ordinary cellulitis and necrotizing cellulitis. When you look at the historical background of this infection, no doubt Hippocrates might have given 1 or 2 lines about that. But in 1871, that is Joseph Joes, who has given the name hospital gangrene to it. After that, and you find Wilson proposed the name necrotizing fasciitis, with which is now popular. So hospital gangrene or NF is a very old condition. Maybe we call it a surgical condition, already delineated in textbook of modern medicines or surgical books. Next, necrotizing fasciitis or NF, hereafter I call it. What is happening there? endothelial cell damage is basically taking place, and wherein the blood supply is prevented, resulting in inflammatory response process, ability to immune system to promptly work is impaired. Similarly, transfer of antibiotics that are given to treat the condition is also not reaching the target place because of poor blood supply. So what is happening? What they have described here is vasoconstriction with the addition of thrombosis leading to edema and hypoxia. This is more important. Whenever there is oxygen supply is impaired, then anaerobic bacteria will replicate. That is what is happening, resulting in necrosis of fascia, skin, soft tissue, and muscles. So whenever there is a nervous involvement, naturally the pain intensity will be more, and that comes in different stages of the disease. Next. As far as pathogens are concerned, next, any toxin causing bacteria is taken and it is divided into two. Type 1 is what we call polymicrobial, and those people who are diabetics are more prone to get it. Type 2 is the most common hemolytic streptococci. As you all know it, common pus-forming cocci, streptococci and staphylococcus aureus. These two will take a different form in initiating the disease process. But at the same time, they have also identified other caused organisms which can contribute for this condition. What are they? E. coli. E. coli is commonly non-pathogenic. It becomes pathogen as we see quite often in UTI. Streptococci pyogenes, aureus, etc. They also participate in finally increasing the infection leading to necrosis. When you look at the early symptoms of NF, let me have another slide, please. Subcutaneous tissue may also have a hot feel on palpation, as we see it initially. Clinically indistinguishable from other soft tissue infections, with only presentation wherein we can record pain, tenderness, and warm skin. These are the three important things which we can take up as an early symptom, basically. Next. So coming to advanced symptoms of NF concern, this is where the disease name has been given, nomenclature basing on initial necrosis appears as a massive destruction of the skin and subcutaneous layer. And normal skin and subcutaneous tissues are also loosened. Initially it was hot, now it is becoming loose, and large dark marks that become blister filled with yellow-green necrotic fluid. So initially it appears like a cellulitis, and later on it becomes a bullous presentation. Critical symptom, definitely critical symptom, you can see in last stage of the NF. 30% of patients develop hemorrhagic bullae. So that leads to also a condition in the patient's body where the hemoglobin is decreasing, leading to anemia. So anemic appearance you can see. Vasculature of skin becomes inflamed and thrombosed, resulting in necrotic scars that look deep thermal burns. At times when you look at the picture of the critical symptoms, a scar-like thing will appear. Now this is a necrotic ascites, how it happens. The entry of bacteria surrounding the skin, whenever there is a way through subcutaneous, it goes up to deep fascia. There are different stages that are described here. Nothing particular in that slide. Next. Common signs and symptoms are concerned. They mimic common less serious condition initially. We may ignore. The tachycardia will be there, metabolic acidosis, edema, and what we call pain greater than visible signs. If the infection continues, what is happening to the deeper tissue damage, pain intensity will come down, including numbness. This is what we see exactly a disease condition described in Ayurveda also. As the disease advances, we will be under wrong impression that signs and symptoms are subsided with our medication, patient will be happy. No sooner he will be entering into critical stage or phase. Next, usual clinical course, the infection starts in 24 hours. 20 to 48 hours, slowly the erythema changes to red to purple color. Then it mimics cellulitis, simple cellulitis. When day 4 and 5, when it is not coming down, the purple area becomes gangrenous. See how fast the infection travels in the skin into the deeper fascia. It takes only 4 to 5 days. Day 7 to 10, the line of demarcation becomes sharply defined. You find the peeling of the skin. A crater is formed in the center, revealing extensive necrosis of subcutaneous tissue. This is what is happening. You can see within 10 days, it will settle down. So as far as stages of skin damage is concerned, it is divided into early, middle, and last. So skin, pink, painful edematous, we call it as erythema, and quickly spreading erythema and ecchymosis. Ecchymosis is once again a little bit of dark color creeps in along with erythema. So endotoxins destroy the flesh. That is the middle stage. Gas produced from this process accumulates, then a bullous forms out of it, and bluish gray to purple. So this is how a middle stage is described. Next. So this is once again a mechanism of necrotizing fasciitis, that is from subcutaneous to deep fascia. In between, they cause inflammatory process changes, and aneurysms are formed in the blood vessels. All destruction initiates there and there, then only. Next, in the late stages of the skin damage, let me have next slide, please. Bullae or vesicle, often purple in color, they form, and in real it is progressive in nature. Subcutaneous necrosis can be perceivable with naked eye, and ultimately the green slough, graying, green slough and deep blue and purple areole which spreads rapidly. So these are the symptoms which you can see from subcutaneous to deeper fascia when the infection spreads. Next, common sites are extremities, abdominal wall, perineum at times, and also this infection you can see in post-operative wounds also. That's why you have to be very careful. Sushruta has taken a lot of care in post-operative procedures after the wound care. You don't find in any surgical book such an extensive deliberations or delineations given by Sushruta. So next, after these things, extremities are mainly involved basically. Diagnosis is concerned, you take a blood sample and elevated or lowered creatinine. Both can be seen. The swing is between elevation and lower values. CPK elevation will be there. CTRI, MRI scan of some help for us. And antibiotic culture is more important. Which antibiotic? The present bacteria that is growing is susceptible. Next. So after this diagnosis, we'll go for treatment. So treatment procedure, please, next slide, please. Treatment procedure is concerned. We have immunoglobulin therapy, usually to boost up the immunity. That means immunity is at a low profile, basically, whenever the infection invades the skin. Heparin is given because traumas are likely to form in the vessel. So to break that and make the platelets not to aggregate further, resulting or increasing the necrosis, by cutting off the blood supply, heparin is given, but heparin got its own risk of vasculitis. Next thing is hyperbaric chamber. Because the bacteria usually becomes anaerobic, that multiplies a twofold, the oxygen to the local area is given to the tissue. This is a procedure where the modern doctors or surgeons say it's controversial. Some group encourages to give O2 and some say it is like a placebo. So strict isolation is needed because it is a highly contagious disease. So hospital gangrene means other people also get affected, those who are having wounds or undergoing post-surgical treatment. So next, such a dreadful disease, do you get any leads when you scan the Ayurvedic literature? Have they come across such condition earlier? If so, what is the recorded evidence? To my mind, when I was searching this, my time was very less basically. When a topic was offered to me, only 24 hours or 36 hours, I can say exactly. So I was going through to looking at the picture of the NF, what it could be. Then to my mind, I found Vanasoda described in Ayurvedic literature is more akin, or NF is more akin to Vanasofa. So Vrana, you know it. Vrana Gatar Vichurane, Vranayati Vranaha. Vranavastu Nanasyati, because once wound is there, the mark will be sustainable for longer periods. So what is Vanasoda? Any swelling locally at one place, if it is seen, that is going to indicate a vrana, upcoming vrana in the body. So it is a prodromal symptom. Ekadosoditam sodo vrananam purva lakshanam. So that Vranasoda also, Ayurvedic acharyas have divided into 6 categories based on the dosha involved in that. So once again, Vranasofa is further divided into 3 stages. As we got enough early stage, middle stage, and late stage, we have a classification when we carefully go through the literature and descriptions. Amavastha, Pachamanavastha, and Pakvavastha. 3 things are there. And let me have another slide, please. When you look at these symptoms that are given very carefully, initially in NF you have a erythema, maybe a slight febrile condition, and locally there is a cellulitis. Local temperature is also on touch. You feel that it is increased. So here the Mandoshmata Alpasodatva, the swelling is not so proportionately high. A little bit of hardness can be palpable, and Manda Vedanata, that is a pain is of low intensity. These are the Ama Lakshanas of Vranasoda. Next, Pachamanavastha. Next, please. So when you look at the Pachamanavastha, that means Vranasofa is entering into 2nd stage, where the intensity of the pain has been expressed in different ways and means, that Dahana, Vedana, Pidana, Choshana, Vivarnatva, and Asane, Saine, Sthane, Shanti, Vrishikavat, Vidhavat. Patient becomes restless and listless basically when the infection travels, so far travels to Pachimanavastha. Here, Ayurveda recorded Jwara, febrile condition. Coming to last stage of Pakvavastha of Vranasopa, about to form either abscess or Vidardi or an ulcer. Vedanopasamaha, as it happened in NF also, when infection is deep-rooted, all the symptoms subside, including pain and numbness. That is what they have recorded. You can find here, Vedanopasamaha, Sodo Ahilahuto Alpo, Nacha Unnataha, Pradurbhavo, Valinam, Todaha, Kandu Muhurmuhu. The patient complains of even slight itching and just like pinpricks. Upadravanam prespo nimnata spotanam tvacham. Slowly the skin starts gapping up. There will be puyasya pede ante. So pus forms. These are the 3 stages given for Vranasofa, and the NF is more akin to this condition according to my view. Next. I will show you. Do we have any such reference where the flesh eating or necrosis has been referred in Ayurveda? Very much. Say, I found out of 3 classical Brotrai, Asanga Sangraha repeatedly given in different contexts about necrosis. The first is Murduman Sataya Sigrameva Pakvaha Sa Kodam Avapya Diryate. Sonidasya Krishnatam Daurgandhya Tanitvat Kledaha Mansashit Krishnada Daurgandhyat Charma Kodaha. So necrosis of the skin is given, including the flesh. Piktan tvachi sthitam kuryat, vispota masurika, rakto visarpan daham, manse mansapaka kodanam. So necrosis of the muscle has been documented even very well in Susu Samhita and more emphatically given by Vagbhata, probably in 6th century, we can say it according to historians' time period. So, next slide, please. You know, Sushruta has given a very broader wound management, which are described as upakarma or measures, into 60 varieties. Such an extensive classification even today is missing in the so-called advanced modern surgery, I can say with confidence. So how much care Sushruta has taken, how the subtle observations he made step by step to wound the heel, how much laborious efforts he has put, and hats off to his meticulous approach towards Vrana. This is enough for us to show the beauty of Ayurveda or the scientific validation done in those days at that point of time. Next slide, please. Next slide, Vrana Sofa. So when I gone to the other textbooks to concise the Sasti Upakramas, as far as Vrana Sofa is concerned, the Upakramas are only 7 in number. Then I have tried to categorize them according to stage Apakwa, Pachamana, Pakwa, wound healing stage, and cosmetic treatment. So what they have given here, Adav Vimalapanam, Kuryat Dvitiyam Avasechanam. Avasechana means applying Shodhana karmas, either it is a Rechana or a Purgation or a Vasti enema, and Raktamokshana is given more emphasis only in Apakwa Avastha. So Pachimana Avastha, only they preferred poultice to be applied, not to disturb the Soda. And when it is come to Pakwa Avastha, you should not ignore it. Definitely incision should be given. Ayurveda is in favor of doing surgery, draining out the material, where I have observed the Sushruta Samhita's beautiful observation, very significant, I can say. Mahanta avakasat krutva nadi janayatva kurchasadhyo bhavate asadhyo vekti. If you don't take care of opening the Vranasoda in Pachamana Avastha, the infection that is pus transforms or permeates into the deeper tissue, leading to sinus formation, which is either incurable or difficult to cure. Such a beautiful observation was made by Sushruta. The reference is in Sutta Chikitsa Sthana, 1st chapter. In the context of Vranasoda, he has given this. So care should be taken. We are for surgery. We have to open the wound. Then followed by that, in wound healing stage, Shodhana and Ropana measures are given. Sushruta has given such a care that the wound then when heals should not, what we call, disfigure your area. So care has been taken in the form of Savarnikarana, cosmetic surgery, what we call, and cosmetic aspect of wound healing, post-wound healing area. And if there is a Roma in that is lost, Roma Sanjanana is adopted, all these will come under E category, that is in the 7th stage, where Vaikurthapa Parana. So Savarnikarana, etc. will come. This is a very broad way approach of Vranasoda management, which holds good to manage NF periodically in different stages. Next slide, please. So further to substantiate what I have shown you in this slide, where I have made the stage-wise implications of Sapta Upakrama, I brought a authentic reference from the same chapter on Vranasoda, Sushruta's approach, where he has taken every care. Then Apakvavastha, you can give a leech application, Raktamokshana, for people who are very soft in nature and delicate constitution, like pediatric cases, women, geriatric patients. Then the management will be different. There we don't directly incise the wound, we apply Prapidana, or dharana procedure in the form of lepa. Then once it is becoming very solid, katina, and then we have to incise it, sastrena, nirliket, and what he has given here, you have to totally debride the wound, residual material also. That is what we are doing in NF also. We don't leave anything behind. Otherwise, the infection spreads into the body. Superficially, you may be ensured that it is not going to do any harm. Next. So, क्लासिकल क्लेम्स, इसके पहले तो कुछ तो होगा. इसके पहले स्लाइड दिखाइए भाई, खोद नाम का. हेलो
निशांत जी, पहली वाली स्लाइड दिखाइए. यस.
नहीं, इसके षडुपक्रम के पहली वाली स्लाइड दिखाइए ना. षडुपक्रम के पहली वाली सर, इसके पहला, इससे भी पहले. हाँ, yes, this is necrosis where I have to actually emphasize. Two things are there. I have given Ashtanga Sangraha and other things. I forgot to emphasize the last observation made only by Madhavakara, though he is not so famous surgeon basically. Kaksham samadaya yadhaiva vanir vaivi riti san dahati tasnakya. Just like a casta, a wood, a fire can make it into a burn. Tadaiva puyo vinishruto hi mansa siras nayuche kadati ha. This is the most important observation I have picked up, which made me to compare NF with Varnasofa. So this is given only by Madhavakara in 7th century, and I have verified whether it is lifted from Sushil Samhita. Not at all. It is observation where the flesh-eating condition was stressed by Madhavakara in the context of Varnasofa, wherein he was discussing that kapha contributing dosha is, puya contributing dosha is kapha, and daha is by pitta, and ruja is by vata. In the consequent sloka he has given. This is the best evidence to stress that we have the concept, they have observed certain bacteria, which we call nishachara or bhuta. They have seen with the wound while they are managing that destruction of the internal structures beneath the skin, up to the level of muscle, tendon, and blood vessels are all going to be affected with the puya or infective bacteria. This is the most important slide in entire my presentation of this evening. To stress why I have compared Varnasofa with NF, this is the most vital point for us. So let you skip kindly. Classical claims. Next. Yeah. So I have recorded to manage such cases. What could be the herbal material they might have used? You are jumping, Baba. Keep it as classical claims. That slide only I want. Go back. Still. Yes, this is important. So what I have observed here, Varna and Krimi, maybe macroscopic or microscopic. So if it is Dushavarna, you find maggots in that. What are all the effective drugs which can control even maggots or the bacteria which is invisible? This is the important formulation. Karanja arista nirgundi rasohanyat vrana krimin. अरे भाई, आप क्यों जंप कर रहे हो? Kindly show the slide what I am explaining. Who is operating there? So Karanja arista is nimba, nirgundi, all these have shown in vitro studies are also very effective in pus-causing bacteria, Staphylococci and Streptococci. So most of the textbooks have given Trifla in the that is Mahantam Saruja Sasodha. Very edematous, very painful, deep-seated vranas also. A kleda paka stuti nirganda yukta vrana, foul smelling. So dusta vranas, the easily accessible for the physician also to apply is Trifla Gugulu. These two things I have taken from Urunda Madhav. Next is a few claims related to Sajjakshata. Sajjakshata, what he has given here, St. Madhu Yuktena Kinchidusnena Sarpisha. St. Madhu will have a profound anti-inflammatory by reducing inflammation, intensity pain also comes down. It is very frequently advocated by Sushruta also. And medieval works like Urunda Madhav have taken very conveniently the Sushrutic material to describe here. And I don't know, another drug, what Urunda only stressed is Kanta Kramuka, that is Musta. Ekam Suslakshanam Gavya Sarpisha Pistam Samayati Niyatam Lepat Vranam Agantum Nasandeha. So Agantas Vranas heal fast with only single drug application, that is Kanta Kramuka. So similarly, we got such claim with Sariba also, that is different division. So Karpasa Phalamisrena Jayet Swadhana Sarpisha. Karpas Phala is given. Somewhere other one important sloka which I have asked my colleague to include, she forgot, is the classical observation made by Sarangdhara. You don't find in other textbooks. Kadgadichinna Gatrasya Takshanam Purito Rasaha Gangeriki Nihatya Saruja. The total pain because of the weapons that are causing sharp-edged weapons causing wounds. The pain can be instantaneously relieved by Gangeriki. Nobody so far documented this. Either they are not aware of this claim or they have got other sources of the drugs to be tried further. In Priyata, I don't know. So Gangeriki is Grevia hirsuta, as it is well established. That is to be tried as a powerful analgesic, even in wound management, that too Sajjokshata. Somewhere or other it is missing in my slide, so I have added it to it. Next, please. So what are all the drugs, the scientific validated data, wherein we can apply to control the bacterial population or bacterial infection in NF? So these all are the drugs which I have listed around, running up to more than 24 here or 34. So all these drugs are somewhere or other having some classical base that they are referred in wound management. And most of these drugs are reported to have a antimicrobial property through in vitro studies. So what we are doing is Ecorus, aloe vera. There are certain drugs in this list which are also reported to have wound healing property. That I have shortlisted here. So these all are popular drugs, as you are well aware of it. You can go through it. उसके नाम बताऊं तो एक खदिर है, एक वचा, एक कुमारी, एक कुलंजन, एक सप्तपर्णी, एक भूनिम्बा, शतावरी, and nimba, brahmi, berbere saracheta, daru haridra. So several such drugs are there. Next, we can go through because the presentation will be with you. The up to gingiber officinal alphabetically I have arranged whatever data I got. And among them, naturally, we prefer to apply always Rubia cardifolia, that is Manjista quite often, along with Haridra in most of the conditions. And of course, terminally Arjuna is also reported to have both antibacterial and wound healing property. Similarly, our aloe vera and also Centella asiatica. Let me have another slide, please. Next slide. I will show you the crystallized list of it. So anti-inflammatory and wound healing. Please don't jump. Show that slide. So anti-inflammatory and wound healing. This is the core list where you can take up for a research. Aloe vera, Berberis aristata, Daru haridra, Arka, and Mandukaparni, Haridra, Kankusta, Arjuna, and Haritaki. So if you want to heat at this inflammatory process you want to stall, Vitex nigundo is having antibacterial property and anti-inflammatory property that can be incorporated. Cyprus rotundus, which was given by Vurunamadav as a sheet anchor in the management of Sajovrana, is also having significant anti-inflammatory property. So such drugs are to be incorporated when you design a formulation. Basically, that is my area where I can share you the formulation with a research validated data. You can take and design your own formulation. So next, we have certain drugs which are extensively studied by different scientists and papers have been published, and Neem and Haridra. Why these two drugs are important? Because these two drugs and the fight between America and India has made us to open our eyes and look into the Ayurvedic literature to generate, to show the evidence. Because America initially started Neem patent rights. Followed by that, we fought in the court of law. Then they have plunged upon Haridra. Then also we fought the case. Then government of India instructed the AYUSH department, you somewhere or other, you produce some evidence. You have any classical literature? Do you have any published data? We have to document it at one place. That has created a chance to open TKDL, Traditional Knowledge Digital Library. Genesis has started with the fight between India and America in the case of neem and turmeric. So these two important drugs have been given in several recipes periodically and repeatedly. When you take from classical works of Susruta up to 18th century or 19th century of Bheshaj Ratnavali, in between all Yoga Sangra Granthas, repeatedly picked up neem leaf as a wound healer. Both wound healer we have to interpret as Vanasodhana and Vanropana. It is a double-edged weapon for us. It purifies by controlling bacteria and facilitates for the body immunity to heal by forming collagen tissue. Same thing with the turmeric. So we did some amount of work in this area I want to share with you at the end. So neem has been published through research papers. And next is, I have shown you here turmeric. Turmeric are also reported by Mehra and Santanam, etc. for its anti-inflammatory, antipyretic, polyherbal wound treatment where the turmeric has been indicated or incorporated. Like that, we got several papers published on turmeric also. Next slide, please. Next. So when we were searching out, we found one paper, herbal preparation. Please don't jump. Earlier slide. Herbal preparation effective in NF. I have seen this here written. Triflakwada, Arogyavardhini. Please next. Gandak Rasayan, Mahamanjistadikada, Panchatikta Grita. Simnath Gugulu inadvertently has been added. They have not given Simnath Gugulu. I will tell you the significant application of Simnath Gugulu in this condition. So with this treatment modality, one case study was reported and published on NF. This is the only one paper, maybe two or three. Because of lack of time, we may have failed to search it very in detail. But definitely this prescription holds good for the management of any Mahakusta or Shudra Kusta, any common mediocre Ayurvedic physician is inclined to prescribe these drugs. So that's what they did. It is a tailor-made prescription. As we see in Jamnagar, we used to have our teacher CP Suklaji. He used to have 200 OP, and mainly his rheumatoid arthritis is the main clinical material used to come to him. Then he has designed his own prescription, wherein Mahavata Vidvansini mixed with Pipali Churna, which is a sedative, and Ashwagandha and Madhusnehi. So I was new to that entry into the 1977 batch MD first year. I was following his OP. Then I asked him, why you added Madhusnehi here? What is the rationality? The teacher did not give immediate reply. On the other hand, asked me to set out the literature and come up with the answer for your question. Those were the teachers. They don't spoon feed you always. They give a scope for you, your nature of doing hard work, whether you really search, your question is genuine or not. So I went to my room earlier and I have searched it. I could not get in the night. I have searched it. Then I found the answer. Next दिन दूसरे दिन हमने उसका जवाब दे दिया. Because it is given, Tanuvedana is included along with Apasmara and Umnavada for Madhusnehi and Ferangi Roga. So I said, because it is given Tanuvedana as indication, for analgesic property, you might have added it. He said, very good. Your search is correct. Your application of mind is correct. He appreciated it. So why I am sharing this prescription with you? This prescription even today is being down, is copied down or being followed in Jamnagar hospitals. Probably the physician may not be knowing the rationality behind it. CP Shukla was a great scholarly physician, according to me. A scholar need not be a physician. A physician seldom a scholar. It is a rare combination I see in CP Shuklaji. So this prescription I am discussing is a tailor-made. Everybody follows all over the country. For any skin disease, they have tried for NF. They found some improvement. And the follow-up studies, they have not given. Some data we have not gone through the details of it. Next slide, please. Next. So, wherein they have started giving the rationality, it is only pharmacological. For writing a paper, they have picked up and written it. Either immunomodulatory activity of Trifluquada was established or not, we don't know. Individually, all the three drugs have been studied for its activity against immunity. Similarly, Aryagvardhini improving liver function is well established. Gandhak Rasayan, Agni Deepak, they said. Gandhak Rasayan, out of all Rasastra drugs, as we have Sunti is the best Jepana Pachana, Pachaniya drug, Musta is also. Similarly, if you go through the textbook of Vagbata, Rasa Ratna Samuche, Gandhakam Amon Mochana Shoshano Vishahara Sutendra Virya Prada. Out of all minerals and metals belonging to the tree of mercurial system, the sulfur is the best amopachika drug. So the ama that is existent in the wound or in the body, which is contributing for the necrosis also should be taken care of. But sulfur as such is the best antimicrobial drug. So Mahamanjistadikara, they have given Panchatikta Grita is they have given. Panchatikta Grita is different. Panchatikta Gugul Grita is different. Panchatikta Gugul Grita contains Vallatak. The activity of it is twofold whenever you want to hit the Kapha dosha dominance in the body. Now coming to NF, what are all the group of drugs that can be taken care of? So Vranaropana drugs, as such you may not get it, but in Charaka Samhita, there is a group known as Sandhani Dasaimani. And Krimigna, definitely it is a krimi, very useful against 20 krimis. Out of that, Raktaja krimi, Kechit, Sokshmyat, Adarsanaha, microscopic. So that contribute for skin manifestation. So the Krimigna group given by Charak as a broad spectrum can be applied in this condition of NF also. Similarly, Kushtagna, Varnya, why? Because the Vrana takes place, Pranavastu Nanasyati, it disfigures the local area and cosmetic problem will arise. So there is a cosmetic treatment, Varnya, Dasyamani to be taken. And because the toxins that are constantly released in the form of bacteria locally, it can be nullified or it can be taken care of by Vishagana Dasyama. So I got two more drugs in my mind. When you want to hasten or accelerate wound healing property, Brahmaniya group of drugs are very, very essential to be applied. So among them, most of the drugs are not available except Ashwagandha, Bala, which is not of a genuine source. So Ashwagandha application in the post-management, a post-necrotic stage should be given to the patient. And Lakaniya group also should be given along with these groups where you want to accelerate the debridement of the tissue. And among that, Musta Haridradvaya Katuki, already it is reported to have a best wound healing property, a very significant antimicrobial property. They are those drugs also attend the Lakaniya process of the wound, which also helps for collagen formation, accelerate it and augment it. So this is precisely the group which are to be considered while designing the formulation. Next. Can I have next slide? So now I'm coming to our publications. Please next slide. अरे भाई बातें कर रहे हो क्या है? Who is operating? Hello? Hello, Sharma ji.
Sir, Professor Nishant Shukla is managing and he is truly yours.
I don't disturb. This is not the way.
Yeah. He might
This
be.
is not the way how you make me to stand in the queue.
Sir, there might be some transaction problem, signal problem. It is a little bit slow. It is just opening.
Next दिखाओ भाई. So what I want to share with you, we have conducted a study under the PhD program, and Dr. Vijay Kumari she's supposed to be the first PhD scholar recorded there, and I have given her Ekam va Sarva Molam Sarva Vrana Vishodhana. So this is observation that has been copied down right from Vrindamadhava up to 17th century Yogaratnakara works. So Sariva application, whether it is really wound healing or not, we have taken up three groups. Honey as one group because honey is a very good wound healer. Vranasodhana Taila, which is very popular in our hospitals of government of AP and government of AP Pharmacopoeia has designed it. Maybe the classical source has been taken up, which consists of mainly 4 drugs. One is Neem, Karkuma Langa, that is Haridra, and Tarpitam, that is Trivrut, and Tila. This oil is very famous in our OP section, IP section. So that we have taken up and studied, and we have published a paper, analytical study of Vranasodhana Taila wound healing, IJRAP. Those who are interested can go and see it. After this, I want to give a historical background of wound healing drugs. Probably the first scientific study on the wound was carried out way back in 1963 by Dr. I. Sanjeev Rao, who happened to be our additional director. He did through animal experimentation by measuring the tensile strength of the muscle. He has taken Mansa Rohini. The paper was published, a really very good study. After that, we have planned a series of studies with Jachadi Thailam, Jachadi Gartam, etc. But the initiation was done, a scientific study from BHU by I. Sanjeev Rao, who belongs to our area. So we have the conclusion part I am coming. We have a tribal information. When you go for botanical survey teams, you can collect maximum number of wound healing drugs because they come across in day-to-day life for injuries. That's why they prefer to search out a plant in the vicinity and they apply. And I have seen one tribal demonstrating me when he had a wound and blood is oozing out. He has plucked one leaf and crushed it and put it on that and started talking to us and started literally walking deep into the forest. I was very carefully observing what he is plucking. So then I have identified it as nothing but a simple drug known to all of us, that is apamarga. Apamarga as a triptych, only one text has quoted. It is not a common plant, but tribal knows the utility of the drug. So if you want to stop it, apamarga may be contributing as a very good wound healing agent. We have to study it. And tribal information is very useful. Those drugs can be incorporated even in management of NF. And I'm coming to conclusion. Necrotizing fasciitis is rapidly spreading inflammatory infection. Initial stages, as we have shared with you, and Vernsofa is the only condition where I can, what we call compare the condition managed in earlier days. And this was recorded at the time of 1000 BC. Enough information started generating from 500 BC onwards, isn't it? And probably in 1817 or so, or 1950, the intensity of the infection was so, people started recording, thinking of its management, etc. But Vernsofa management is very extensive, and all those clinical management or surgical management clearly matches with management of NF that is being followed today. So Madhavkara definitely is to be credited for giving us an idea how a flesh is eaten by pus-causing organisms, how Snayu or Sira is involved in the Vernsofa. It is not a credit given to Susruta. It is only Madhavkara who first time mentioned flesh-eating bacteria or flesh-eating condition in Ayurveda. And Susruta suggested Jalukavacharna to prevent Paka of Sofa. Dharana and Pedana is given for Pachamanavastha, as we have already explained to you. And some delicate constituent patients are belonging to pediatric, geriatric, and female gender. They can be given external application. And finally, whoever they may be, we can't spare when they enter into the Pakvavastha. Incision is a mandatory procedure. So suggested debridement without leaving any remnant material, as Susruta has stressed it further. After Sasadekasa, wound should be treated with suitable upakrama. We have 7, we have 60 at the end. Whichever is suitable according to the condition can be picked up. But our excellent delineations by Susruta, I don't know how many Nobel Prizes he deserves, if at all he is in our time. And herbs like Kumari, Haridra, which are also having antimicrobial, wound healing property reported, validated properly, can be incorporated in your formulation. And among Gugulu, my favorite Gugulu is always Simanath Gugulu, because it is the only Gugulu preparation which contains sulfur for its antimicrobial property. But classical authentic information is in favor of Trifla Gugulu, Saptavinshati Gugulu. This is once you start curtailing or preventing inflammation, it will come down. So before I leave my talk, I want to share with you, tribal system has generated a lot of information on various herbs. Certain herbs are not quoted in Ayurveda. Certain drugs are having classical references. With one such a tribal claim came up to the physician's hands, put it into practice is only one so far, that is Arogya Pacha. Arogya Pacha means Trichopus gelanicus. And I was in Central Council working for some time at Madras. Now it is Chennai. And I have come across the annual reports I was reviewing while supervising I-64 double-blind clinical trials. So Yoga Narasimhan, when we went on ethnopharmacological survey as a head in Kani forest area, at the foot of the hill, a tribal guide has offered him one fruit. A fruit he has swallowed, and he has trekked up to 4 or 5 kilometers to reach the summit of the hill. Whenever you go on an expedition or such a survey work, we carry less luggage with us, a water bottle and few biscuits or sandwiches. So when he reached the top, he realized why I did not open my water bottle cap, why I could not munch the biscuit or sandwich. What could be the reason? Something is there. Scientist only applies a very, very important sense, that is common sense. We need not be very intelligent always. So he applied it and immediately asked the tribal guide, what fruits you have given me? He has called it as Arogya Pacha. So that material was brought to the lab, analysis was done, through reverse pharmacology, clinical trial was done. They have Rasgonoviripaca superficially they gave, and finally that drug has been marketed through Ayurveda Coimbatore in the name of Sanjeevani. I was prescribing to my AIDS patients, where I found CD count is improving. Our Ashwagandha also did a very good job in that. So that's what I am telling you. A tribal Ayurveda is because of tribal source. One integration happened with Brahma, who has remembered Ayurveda, given some basic concepts to Bharadwaja or Atreya. That is first integration. You don't believe that mythology, keep it aside. According to me, second integration is from tribal pockets. Gopala Stapasa Vyadha Yech Anye Vanacharina Mulaharasa Yetebhyo Beshajam Vyaktirishate. From the tribal, they brought it and they have used their analytical mind, incorporated and expanded Ayurvedic materia medica. There is a scope for us as far as wound healing herbs are concerned. We can expand our materia medica and application, provided you carefully analyze the ethno-medical medicinal data properly and a proper validation through clinical trial only. That is more important. So I thank once again Pawan Sharma ji and other organizers who are with me for having given a patient ear to me. And I once again I am happy to see my ex-colleague Prajapati ji, who is now Vice Chancellor of Rajasthan University, for his participation in this. I thank once again all. At the end, I want to once again acknowledge this presentation would not have taken present shape unless the help and cooperation given by my colleague and student, Dr. Prasanna ji. She has taken a lot of pains to give me within short notice.
आप म्यूट हो गए सर. Thank you, sir. Thank you. Thank you so much, sir. It's a great pleasure to. Sir, आप म्यूट हो गए हैं. Yes. Okay, sir. Thank you so much for your great presentation. Yes, sir.
Thank you.
Yes, it's our great pleasure to have your presentation today at such a senior person holding full command, and this is what the pleasure of Devgund itself. You very nicely shown the path to which we can understand the necrotizing fasciitis. Because before it, we were all scared that what is there, but the light and the route you shown, it became very clear. And during your presentation, we have got a lot of information from Professor L.K. Dwivedi ji. He talked about some important words like Mansad Kramived. We can also classify in the way, and at the same time the Drona Pushpi Kalka, Swaras, Swedan, and Shilajit Lep.
Oh.
These may be better for the Sadhabrana. At the same time, he also talked about the Jatyadi cell having the Tuthya in that preparation. So your line of thinking made us all thinking that in what way we can go for the this Koth, Shoth, and the Gangarian. So this is what it was well detailed described where in 2000 years back, 1000 BC and all. So, and you also very easily uttered a very few words in the favor of, as a compliment in the favor of Professor, our Guruji C.P. Shukla Sahab, that scholarly physician. I noted on the word, how spontaneously you told scholarly physician, and you also noted that a scholar may be physician, but a physician may not be a scholar. This is I have seen Professor S.D. Upadhyay with here he was completely ocean of knowledge, but as far as the clinical practice is concerned, he never gone for the clinical practice, having their time in our Rishikul Haridwar. So you uttered strictly on the words the you have seen or as the apt persons. This is what we are enjoying, and the progeny is here. Professor Nishant Shukla, you 2-3 times scolded Dr. Nishant Shukla, but he is helpless because the network was not so easy. As
No,
long
no.
it was.
You said sorry from my end because I am a little bit impatient.
No, because I am seeing all this. I am scared that your anger cannot be faced by anybody because you are a so senior person. Everybody is
Not like
scared. And Professor Pawan Sharma is having a 3-flight tiredness. So he just handed me our Professor Prajapati is very much with us, and it is his moral support that we are all here. And I am also sorry for the third webinar, which has been scheduled at about 9:30. So we are 1 hour late. Our 2 ladies who have got the small kids with them, so they are just in waiting. So with these words, I am thanking you again, and it will be your pleasure whenever you will join with us. Thank you so much. Thank you, sir.
Thank you.
Please.
Thank you very much, sir. Thank you.
Thank you, sir. Thank you.
Right.
I think if the link will be made by Professor Nishant Shukla ji, as Professor Pawan Sharma ji informed us. Yes, he is here. He is here. Thank you, sir. Sir, please close and go for the third webinar. Please. Over to Pawan Sharma.
Thank you very much, sir. निष्ठेश्वर सर जय हो, आपकी जय हो सर.
Ah,
आप
thank
जुड़ते
you.
रहिएगा, ये मंच आपका हुआ. जरूर, बहुत अच्छा, बहुत इंस्पायरिंग सर.
Thank you. Thank you. Thank you. Thank you.
Thank you very much. Thank you very much, sir.
Thank you. Thank you.
अग्निहोत्री सर 2 मिनट.
Wasting time, I am really thankful for our 2 new guest speakers of our third webinar, and they are going to talk over the say importance of the